Hello, my name's Sarah Stewart-Smith. I'm one of the haematology consultants at King's College Hospital, and I'm going to give a presentation which we gave yesterday to the Sickle patient support group about COVID-19 and vaccination, so that it can go onto the YouTube channel for STSTN. So I'm going to try and cover the symptoms of COVID-19, which I think are pretty well known to us all now, a bit about the outcome data in sickle cell patients who've contracted COVID-19. I'll discuss something about shielding, some changes in our services due to the pandemic, some of which are good and positive. I want to talk to you about whether it's dangerous coming to the hospital, and the answer is no, and then discuss antibody testing and vaccination. So typical symptoms of COVID: a fever, not necessarily very high, so 37.8 and above, anosmia, so a loss of smell or taste, a dry cough, fatigue, shortness of breath, myalgia, which just means sort of aching muscles, and arthralgia, aching joints, and sore throat, and headache. Headache's quite a prominent one. But some people do present with just nasal congestion or diarrhea, vomiting, so it can be a very variable presentation. Here's a picture of the coronavirus, and this red bit here with a sort of triangular end is the spike protein, and we're going to talk about that more now. That's the protein that most of the vaccinations are targeted against. So clinically extremely vulnerable. Patients with sickle cell disease have been designated clinically extremely vulnerable, and that includes hemoglobin SS, S-beta thalassemia, SC, and any other subtypes of sickle cell disease. And they are advised to shield in order to avoid becoming affected. So how frequent and how severe has COVID-19 infection been for people with sickle cell disease? So since March, the National Haemoglobinopathy Panel of Doctors have been video conferencing regularly to discuss COVID-19 affecting their sickle patients. And it's a confidential discussion with no patient identifiable details. And the group reviews the NHS England guidance and advises NHS England and patient support groups. And the hospitals across England send in anonymised data, so we can't see anybody's name or other identifiable details. So we send in the details about our cases and how they've done. So we've so far had about 500 proven or suspected COVID-19 cases across England, and nearly all of these have been proven now with swabs. In the early part of the pandemic, there wasn't testing available for everybody, but we've gone back and done antibody tests in a lot of those cases. So these are nearly, I would say, 95% or more definite COVID-19 cases. And most of them are SS, and that's mostly just because SS is commoner than SC. So about 80% SS, and most of them are adults. And we know that actually, weirdly, COVID is much more of an issue in adults, and children are pretty much spared from the problems associated with COVID. More than a quarter are managed at home, so that's quite interesting. So 1 in 4 people didn't need admission. Men and women were just as likely to be admitted, men or women, which is different to the general population where men are slightly more likely to be admitted. And fewer than 1 in 10 of the admitted patients needed to go to intensive care, so that's good news. And of the children, none required intensive care and none died. So what was the outcome? So more than 95% recovered, but sadly around just under 5% died. It's not a complete picture because some people are still being treated and the figures change very slightly every month or so. But those who died were much more likely than the others who survived to have significant medical problems such as heart disease, cancer, kidney disease, diabetes and high blood pressure. So there isn't really enough data to say that sickle patients definitely do worse than a general population, but and children with sickle in particular, if they don't have any other risk factors, don't seem to have an increased risk of severe COVID-19 illness. And the consensus view, so the agreement from doctors, is that children with sickle should get on with their education and not be too much held back. Obviously they have to socially distance and take the other hygiene measures like wearing a mask and washing their hands regularly, just like the rest of the population, but otherwise not very much more needed unless they have other risk factors. Adults with sickle are considered clinically extremely vulnerable and should follow they're advised to follow the government shielding guidance. But it is interesting to know that some people with sickle cell disease had few or no symptoms of COVID-19. We particularly saw this in patients coming up for routine procedures who had a swab 48 hours before, which is the part of the protocol. So they might have been coming for a red cell exchange transfusion and had a swab 2 days before and just found out they were COVID-19 positive without having had any symptoms. So what were the main predictors of a worse outcome, or by which I mean going to intensive care or dying? So age was the most important predictor. So there weren't deaths in the under 20 age group. Nearly a vast majority of patients were in the 20 to 40 age group. That's probably because most of our patients are in that age group, and also that they're out and about getting on with life. And they had about a 5% death rate. The over 60s had the highest mortality at about 40%. So quite a clear message that if you're over 60 with sickle cell disease, it's sensible to stringently shield at home and be careful to avoid COVID-19 infection and to seek early vaccination. Those with comorbidities, so that's other diseases such as heart and lung disease and diabetes, had a higher risk of ITU or death, but it didn't make much difference if it was SC or SS, similar outcomes, and the similar risk factors as for the general population, so age and heart and lung disease and diabetes. So what if you get unwell now during the COVID-19 pandemic? Well, our very clear message is don't stay at home ill without telling anyone. Use the emergency services, including 999 as usual, or contact your clinical nurse specialist, your sickle nurse or your sickle doctors to discuss whether you need to come to hospital. Here at King's, we've got separate units, and many of the hospitals will have the same setup. So there's a haematology assessment unit, open 9 till 5 on weekdays opposite Davidson Ward on the 2nd floor for people with possible or positive COVID-19, and a haematology support unit on the ground floor, which is just by our usual haematology outpatients if you've got no COVID-19 symptoms. And you'll be tested at the door of that unit, temperature and a quick series of tests to make sure that you're safe to enter that unit, because we don't want people with COVID symptoms going there, because that's where we're seeing people who have not got COVID, and we're trying to protect that group. There's ward isolation rooms if you're admitted and there's no COVID result yet, so you can be kept there while we wait for the result. And then there's COVID negative wards for people who are definitely COVID negative. But remember, not all coughs and colds is COVID-19, and prompt antibiotic treatment can save lives. So we're still seeing people with chest crises or pneumonia caused by bacteria, and we really want to see those people promptly so that we can treat them and get them better. So is coming to hospital dangerous? And there's a big no. I really don't think coming to hospital is dangerous. I know a lot of people are very, very concerned about coming to hospital, and some people have really delayed presenting and turned up very, very sick and got very unwell as a result. But the hospital, there's clear COVID-free areas. All the staff will be wearing gloves, apron, mask and visor when they examine you. There's a one-way hospital corridor traffic. There's no visitors. So the corridors, you wouldn't recognise them. It's very, very quiet. There's alcohol gel at the entry. Security are there to make sure only people that need to come into the hospital can come in, and to ensure that people wear their masks and alcohol gel their hands. And all the staff have a swab every week, and obviously if it's positive they're not allowed to come to work, and all the inpatients are swabbed twice a week, and most of the staff have now been vaccinated. So I think coming to hospital is the right thing to do if you're unwell. And what can you do to stay well? Well, there's all the usual things that I'm sure you're all brilliant at doing anyway, but focus on your physical and mental health routine. Routine is what our bodies are built for. So getting enough sleep, getting up, going for walks outside if it's a nice day, keeping physically and mentally active, keeping in touch with friends and family electronically, take your prescribed medication. If you run out, remember, we can send it to you now. It's all very straightforward. We can send controlled drugs such as morphine or oxycodone by courier to your home address. We can send your hydroxycarbamide to your home address. So don't run out of medication. You can contact your GP for your usual repeat prescriptions, or if you need emergency treatment with strong opiates, or you need a supply of your chelating agents, that's things to remove iron, which have to be prescribed by hospital, or hydroxycarbamide, we can send those to you. Try and make sure that your asthma or your diabetes or your blood pressure is controlled. So these are things that you've got lots of control over. Take your inhalers regularly, monitor your diabetes and stick to diabetic diets. Monitor your blood pressure at home. That's all very important, and you're the ones that can drive that. Try and exercise regularly. Maintain a healthy weight and a healthy diet, drink plenty of water, especially in hot weather, not that we're having much of that at the moment. And vitamin D supplementation is another thing we'd like you to take. So there's been very clear message from the Chief Medical Officer that we should, all of us, be taking vitamin D during the winter months. That's the sunshine vitamin, and this country is just not sunny. And if you're mostly shielding at home and you're dressing sensibly when you go out, so you're covering your skin, and if you've got dark skin as well, there's very little sun exposure happening. So vitamin D every day, you can buy it at the supermarket, about 1,000 units a day, or we can send you some out, or the GP can prescribe it. So I've done this kit picture before, but I've updated it a bit, and I've suggested that as well as mask and gloves, a thermometer, your supply of medication, particularly vitamin D and some pain relief and antibiotics, a Dosset box, you should think about investing. I think all of us should think about investing in things like a home pulse oximeter to monitor your blood oxygen levels, because really one of the big determinants of do you have to come to hospital will be, is your oxygen level low? And if you can ring us up and say, you know, my pulse is 90 and my oxygen saturation is 99 and the pain is manageable, then we won't, you know, persuade you to come up to the hospital, particularly if you haven't got a temperature. But if you've got a low oxygen saturation, or your very fast heart rate, or a high fever, then that's a really clear indication for a real need to come to hospital. So it'll really help you and us make that decision. And the other thing is a home blood pressure monitor, because blood pressure is important for all of us, but it's much more important for people with sickle cell, because high blood pressure can damage your brain, your heart, and your kidneys. These are really vital organs, and it's much more critical that blood pressure is kept under control in patients with sickle cell. So we're aiming for ideally 120/70, but certainly less than 130/80. And the only way to really know your blood pressure is to check it at home. You might go to the GP and have it checked, but it's hard to get access to GPs now, hard to come to the hospital. And actually, when you get your blood pressure checked in those situations, you might be a little bit stressed and the blood pressure might be a little bit higher than usual, so we don't get such a good figure. So a home blood pressure machine I'd really advise for about sort of £20. So everyone's been told to shield. What is shielding? It's just stringent social distancing. So just being really careful to avoid exposure to COVID. And it was relaxed in May to include going outside for exercise or fresh air. And I think that's very sensible. And previously we were told, well, advised not to leave the house except to attend medical appointments. But do remember, this is advice. It's not compulsory. It's entirely up to you what you do. No one's going to police this. This is your decision and your perception of risk. We do suggest that you work from home if you can. If you can't, it's reasonable to consider applying for additional benefits, because we prefer that you didn't go out to the workplace during this, particularly during lockdown times. And if you are considering going back to work, get an individual workplace risk assessment from your employer. That's particularly important if your role is relatively high risk. So these are sort of people-facing roles such as transport work, teaching, caring, nurse, doctor, nursery nurse. All of those tasks that involve interaction, close interaction with other people, give you a higher risk of catching COVID-19. Explore the work from home options. You'd be amazed what you could do from home. So you might be a nurse or a teacher. There's very good roles for you to be doing telephone clinics or online teaching, and there'll be other people with lower risks that can do the face-to-face teaching or caring. So don't feel pressurized to return to the workplace. Prioritize your safety. So there have been some positive changes in the pandemic. One of them is the telephone clinic. So I know a lot of you have waited hours in the outpatient department, and I apologise for that in the past. But now you can have a telephone clinic. They won't always be exactly at the correct time, because we're often juggling other inpatient workload, and there's a lot of staff off sick or shielding at home themselves. But you will get your telephone call, and you'll be in the comfort of your own home, and just keep your eye on the phone, and we'll try and call as close to your appointment time as possible. Medication delivery is great. We're always told no, we can't send out controlled drugs or hydroxycarbamide, but now we can. And obviously, actually, if we send out your medication, there's no prescription charges, which is another good thing. There's a reduced monitoring requirement for those on hydroxycarbamide. So we used to ask you to come in every sort of 2 to 12 weeks, whereas now it's accepted that 4 to 6 months blood tests, if you've got stable blood tests and a stable dose, is good. And then there's a satellite blood testing service, which means that you can get some bloods done without necessarily coming up to King's, particularly if you live relatively distant from King's. So you can still come to King's, the Golden Jubilee wing, nice extended hours, 7:30 till 4:45, Monday to Friday. We have our own phlebotomy in the last room, an outpatient clinic. So room 7 has now got a phlebotomist sitting in it, so you can come there 9 till 4. Dulwich Community Hospital, Orpington, Beckenham Beacon, the Prue. So because some of you will still need bloods, hydroxycarbamide users will need 4 monthly blood tests, and people who've recently started or changed dose a bit more frequently. And we still would like people to have their annual review bloods, and we can put them off to a certain extent, but we do want to monitor you, make sure that kidney function and other parameters are satisfactory. There's also some of these vans around, these St John's ambulance vans parked outside hospitals. So I know a lot of people are quite worried about coming into hospital because they feel that they might be at risk of catching COVID. But even at King's, we've got a St John's ambulance parked outside Unit 4, so you don't have to come into the main building. You can go to that area outside Unit 4, and St John's ambulance will take your blood tests. And other places, if you live locally, are places like Erith, Queen Mary's, Eltham, Queen Elizabeth, Plumstead and Darrant Valley. Some of them need pre-booking. So let us know if you want to do your test that way and we'll set it up for you. Antibody testing is interesting. We can provide antibody testing. It's not really a routinely available test, but I have done it for a few patients, particularly people that have got a reason to travel, so perhaps a funeral to attend, and they think they might have had COVID. They're very anxious about going. It's quite reassuring if you know you've got a positive antibody. So I have had a few situations where that's been useful. But interpretation of results is not clear. So what does a positive antibody test mean? None of us really know how high an antibody needs to be in order to protect us from COVID-19. All it really tells you is that you've been exposed, you've survived, and you've got some level of immune protection. But does it mean you can relax shielding? Probably not. For all we know, the level will gradually peter out over the next few months, and then how long it is likely that it won't be effective for longer than 5 months or so. Can you return to work on that basis? Possibly not. But it's an individual balance of risk and benefit for everyone. In terms of school, we are suggesting that patients with sickle cell disease do go back to school because of the very good outcomes in young people with or without a positive antibody test. If you have a negative antibody test, what does that mean? Well, it means you remain unexposed. So well done, shielding worked. You were really rigorous, but perhaps it suggests that you should keep on shielding because you don't have any immunity. So it's not routinely available, but I would be happy to consider it if somebody has a particular reason to want it done. It's not a very quick turnaround time either. It tends to take about up to a couple of weeks. Vaccination, this is the real reason for the talk. So they are now available, and most of the frontline staff have already been vaccinated, and many of the over 80s and over 75s. And you're a high priority. You're going to start hearing from your GP practices, if you haven't already, to arrange an appointment to come and be vaccinated. So in terms of the staff at in the hospital at King's, or the people that are working on site at the moment, all of the nurses, psychologists and consultants and junior staff have been vaccinated. So, we clearly think it's safe. How does a virus like COVID work? So viruses don't do anything if they're not inside a cell. But once inside the cells, they can quickly multiply to cause infections. And a tiny bit of virus, an antigen, can be recognized by our immune system. And viruses are based on the body seeing a tiny bit of the virus and making antibodies against it, and also a T-cell memory. And after that, most people have lifelong protection. So for instance, with hepatitis B, many of you will be vaccinated against hepatitis B. You get your first dose, 3 months later, another dose. And after 3 doses, most people will have a lifelong protection. We sometimes give a booster after 5 years, but it's a long duration of protection. So there's 3 vaccines that are licensed and 2 which are currently available. So the Pfizer and the Oxford vaccine, and then the Moderna vaccine, which is not quite in circulation yet, but has got a license. So the Pfizer vaccine is great, but it has to be kept very, very cold at -80. So that's mostly given to people in hospitals because it's only hospitals that have big -80 freezers. Whereas the Oxford vaccine can be kept in the fridge, and that's the one that will be mostly distributed by GPs and pharmacists because they've got standard fridges. But they're both based on this spike protein, that red little triangular sticky out bit that we were looking at on a COVID virus. And they make bits of the spike protein which the body recognises when we see the real virus. But they do not contain COVID-19, so you cannot contract, you can't catch COVID-19 from the vaccination. It's just not possible. So what can they do? So in the trials, they reduced the number of people who got COVID, so that's what we all want. The Pfizer trial included 42,000 people, and they randomly assigned half of them to the experimental vaccine and half of them to placebo. So that's just, they didn't get the vaccine. They didn't know that they didn't get the vaccine, but they were just given something else. And 170 people fell ill with COVID, 8 in the vaccine group and 162 in the placebo group. So that made it 95% effective. So nothing's ever 100% effective, but that's a very highly effective vaccine. And the one issue has been that people with previous severe anaphylaxis, so these are the sort of people that carry an EpiPen because they can get, collapse with very severe allergies, they should probably avoid the Pfizer vaccine. If you've just got a allergy to penicillin, or you get a slight rash with it or something, that's not a reason to avoid the Pfizer vaccine. The Oxford vaccine trials involved over 23,000 participants. 131 fell ill with COVID, 30 in the vaccinated group, 101 in the control group, making it 70% effective. So still highly effective, useful vaccine. So what can't they do? They definitely cannot give you COVID, but they also cannot guarantee that you won't get COVID. And they can't guarantee that you won't spread COVID, although we're quite hopeful that they'll reduce the spread a lot. So you might be thinking, which one should I have? I mean, the reality is you're very unlikely to get a choice. If you get it in the hospital, it'll probably be Pfizer. And if you get it in the community, it'll probably be the Oxford vaccine, just because of the logistics of having a fridge or a -80 freezer. But we do know if you don't have a vaccine, then you are very likely to get COVID and you could get very sick. And if you have a vaccine, this risk falls. So the sooner you have a dose of vaccine, the better the chances that you won't become ill with COVID. So have the first vaccine you're offered, whatever it is, it's Pfizer, Oxford or Moderna. All of them are licensed, all of them are safe, and they all work. So the key thing is to just receive one. I know there's been loads of stuff on social media about, are they safe? And I mean, I seriously think a lot of people have got too much time on their hands. We've all been vaccinated with all sorts of things: measles, mumps, rubella, hepatitis B. Many patients have had their pneumococcal vaccine. These are just vaccines like any other. It's very well established technology. People say, how are they made so quickly? Well, there's been a massive coordinated international effort. These are the biggest trials we've seen. Thousands volunteered to participate, which we don't normally see. Scientists and trial doctors worked all hours and at speed, and the regulatory agencies who usually sit on this paperwork for months and months and months worked extra hours and extra speed, and the manufacturers produced as fast as they could at the same time as testing was occurring. So everything was completed, the trials completed, the vaccinations licensed, and they've now been given to millions of individuals throughout the UK. So you are not a guinea pig. These are established vaccinations. So I've seen, apparently there's a video going around of somebody who claims to be a nurse saying that she had the vaccine and got Bell's palsy, which is a sort of loss of muscle power to one side of the face. But you will not get Bell's palsy from the vaccine. Safety data from more than 38,000 participants showed a favourable safety profile. Common adverse events. So things will happen when you get the vaccination. 84% get some pain at the injection site, and some of that's intentional because you need an irritant to make your body notice you've been vaccinated with something so that your immune system starts to recognize the protein and make antibodies against it. Fatigue and headaches are quite common, muscle pain and chills and joint pain and fever. This is usually just for 24 hours, so a paracetamol or two, and perfectly manageable. Serious events were really rare and mostly after the second dose rather than the first dose, and particularly in older people over 55 years of age. Oh, sorry, less in older people over 55 years of age. A bit commoner in younger participants, but still very unusual. And by serious, I just mean events that needed treatment, not that led to death or long-term problems. There were no more cases of Bell's palsy in the vaccinated group than expected, given the incidence of Bell's palsy in the general population. It's quite a common neurological problem, this sort of weakening of one side of the face gets better after a few months. So if you're going to look at thousands of people, tens of thousands of people, there will be some episodes of this occurring in both the untreated and the treated group. But although it occurred in both the vaccinated and the unvaccinated group, there was no difference between the two. Even once you're vaccinated, you mustn't stop these hygiene measures. So washing your hands, covering your face in areas where you can't be distanced, and keeping your social distance. And we do know that people, including healthcare professionals that have had a vaccine, can later on swab positive for COVID. So that means that they could detect low levels of the virus in the nose or the back of the throat. Doesn't necessarily mean that they were ill. In fact, they're not usually got any symptoms at all, but just that they breathed in the virus, and it's detectable by very, very sensitive means. So not necessarily capable of spreading it, but potentially. So that's why we say even once you're vaccinated, you still got to stick to the rules. So in the patient support group, we had a sort of question and answer session, which I can't quite do without patients. But anyway, can I have the COVID-19 vaccination if I have sickle cell disease? Yes. If I'm on hydroxycarbamide, definitely. So some people felt hydroxy, counted as a chemotherapy agent and might make them immunosuppressed. We use it at very low doses. It's just to sort of slightly suppress an overactive marrow. You're not immunosuppressed by it. And even if you were immunosuppressed, all the more reason to have your COVID vaccine, because you're at higher risk of catching COVID, well, or at least of doing badly once you catch COVID if you're immunosuppressed. So yes, yes, yes. Can I have COVID vaccination if I have a splenectomy? Yep. Definitely, absolutely, definitely. And can I have it if I've had COVID? Interesting question. So I've had COVID back in April and I've had my COVID vaccination. The answer is a very definite yes. We had lots of other questions. I'm trying to think of some of them. Some people said, did it contain DNA and would it get incorporated into your own DNA? And the answer is no, it doesn't contain DNA. Could it make you infertile? I don't know where that came from, but no, the COVID vaccine doesn't make you infertile. Does it contain fetal cells, so cells from embryos? And the answer is no, it doesn't. Could it change your personality? No, it might make you a bit more relaxed, I suppose, just because you're not going to be likely to get very sick and ill with COVID. But I don't know why there is so much misinformation and fake news about COVID vaccines, but it really is fake news. There's some very good real news if you look on the NHS websites, but I would really encourage you to get your COVID-19 vaccinations. Clearly, it's an individual decision. You can make your own mind up, but I would advise you to. And nearly all of us healthcare professionals have had it, and I just hope that you all stay well and have your vaccines. Thank you for listening.